Good morning. This is Dr. John Bennett from Miami Beach, Florida, home of Neurosurgical TV. We have another in the series of the Art of Brain Surgery Masterclass with James Liu, a neurosurgeon from Rutgers. And it's all okay, James, welcome, and it's all yours.
Great. Thank you, John. Let me go ahead and share my screen.
Yeah, perfect.
Okay, great. Terrific. Well, good morning and welcome to the fourth installment of our masterclass series, The Art of Brain Surgery. Today's episode will be focused on pituitary tumors and tumors in and around the area that we call the paracellular region of the skull base, with the emphasis on the endoscopic endonasal approaches. So when we think about pituitary surgery, we're celebrating really almost a century of evolution. And the idea of getting to the pituitary region has evolved as early as almost 100 years ago. And this paper that we wrote some years ago really details the evolution of that. And if you look at it, it really started out, with frontal approaches through a craniotomy. And even as early as 100 years ago, people were debating whether to come to the pituitary either through the nose or through the skull from above. And if you look at Harvey Cushing's first case of transsphenoidal surgery, it really launched the era of pituitary surgery. And this was his classic case of a farmer who had acromegaly with the gross changes that you see here with enlarged hands and feet and coarse facial features. And when he did this approach, it was done through a transfacial incision that he called the omega incision that was tailored just between the eyes and the forehead that allowed him access through the ethmoidal sinuses to get to the tumor. And he later on adopted a sublabial incision under the lip where he used a vaginal speculum to get to the cella, to get to the tumor. And interestingly, he abandoned the transnasal approach by 1929 and used this frontal orbital type approach through a craniotomy to get to pituitary tumors. And Cushing at the time was the leader of American neurosurgery. So one would think that everybody would follow his trend and abandon transsphenoidal surgery. Luckily, he had a lineage of pupils, namely Norman Dott from Scotland, who continued to preserve the transsphenoidal technique, who then passed it on to Gérard Guillot of Paris, who then passed it on to Jules Hardy of Montreal. And these were the key players that continued to revive and resurrect and preserve the art of transsphenoidal surgery. And Jules Hardy was credited to introducing the microscope, which allowed much better visualization that allowed him to see the planes between the tumor and the normal gland to do what we call selective adenomectomy and preserve the normal gland, as you would do in Cushing's disease. Later on in the late 80s, Professor Martin Weiss from USC introduced the concept of the extended transsphenoidal approach, where you would move the speculum to various corridors to get either to the suprasellar or infrasellar clival region. And these were done with a microscope. And in the late 90s, the use of the endoscope became popularized. And Haidong Zhou of Pittsburgh published his series of 50 patients undergoing pituitary endoscopic surgery. And this was the early births of endoscopic endonasal surgery into the modern era that was further popularized by the UPMC group with Kassam, Gardner, and Snyderman. So the workhorse of endoscopic endonasal surgery in the modern era really is the transcellular corridor. And this is to access, vast majority of pituitary adenomas. And from there, we've been able to expand the corridors into various regions of the ventral skull base, as anterior as the frontal sinus, down to the craniocervical junction. And we can also get into the lateral corridors.
Trọng ơi, Trọng. Cái trên cái web chính chạy rồi đấy.
Can we mute the other panelists, please? So we can also get into the lateral corridors here into the Meckel's cave, middle fossa, and infratemporal fossa as well. So not only can we extend our corridors in the sagittal plane, but also in the coronal plane. But today we're going to focus mostly on the transcellular and paracellular regions. And pituitary tumors is really the workhorse in terms of the type of pathology that we treat, vastly through this approach. And they're a common tumor, as common as 1 in 4 or 1 in 5 people in the population based on autopsy and radiological studies. And it's the third most common primary intracranial tumor behind gliomas and meningiomas, with an annual incidence of 8.2 to 14.7 per 100,000 people. And the clinical manifestation can be either hypersecretion of the tumor with various hormones that you see here, or you can get pituitary insufficiency in non-secreting tumors, such as non-functioning macroadenomas. And of course, as the tumors get larger, you can get mass effect with compression with the visual apparatus, resulting in visual loss. In some instances, as much as 1 in 9 or 1 in 15 people can have a spontaneous hemorrhage or infarct into the pre-existing tumor and present with pituitary tumor apoplexy. And these typically can have a triad of acute headaches, visual loss, and then lateral compression, resulting in diplopia due to oculomotor deficits. Now, the radiographic findings are very classic. You want to look for a tumor that's partially enhancing or heterogeneously enhancing or even non-enhancing. And this bright signal that you see here is blood products, where you can see it on the T1 image without gadolinium. And with gadolinium, you'll see that there's lack of enhancement due to infarction of the tumor. And in some cases, you can see thickening of the sphenoid sinus mucosa. So this is a patient who presented with pituitary apoplexy, who had acute headache, nausea, vomiting, and diplopia, and blurred vision. And these patients largely present also with hypopituitarism with low cortisol levels. So it's important that you recognize this and you check the cortisol and you replace them early with stress replacement of hydrocortisone. Surgical timing, I think, is important. I usually like to take these patients acutely, and I think it's important to emergently decompress the optic chiasm if there's visual compression. So as soon as possible, we go in, and you can see the tumor here is already filling the sphenoid sinus. And the tumor here is largely necrotic. So it tends to be white, necrotic appearing. And once we remove the tumor, you can see this is the descent of the cellular barrier. The cellular barrier is defined as the arachnoid membrane that protects the CSF space above. And the cellular barrier can be made of the arachnoid membrane. And there's also variable thicknesses of the gland, the normal pituitary gland that is on that arachnoid membrane. A lot of people call this the diaphragm. I don't think diaphragm is necessarily the most accurate term. A diaphragm is mostly the dural opening of the diaphragma sella. that communicates from the cellar to the suprasellar compartment. So I like the term cellar barrier, and that was really popularized by our friend and colleague Alvaro Campero, and we published a multi-center series in the last several years on the cellar barrier. And so here you can see the cellar barrier has descended, and when you see this descent of the barrier and it's pulsating with CSF, this is a good sign that you've decompressed the suprasellar component and the optic chiasm is decompressed. So look at this, the pre-op and post-op, look at how the tumor's been removed. You see the cellar barrier has descended into the cellar cavity, and you can see now the optic nerves are decompressed. And this is the post-op day 1 MRI. This is the immediate MRI scan. And you can see how the descent and restoration of the pituitary stalk is now visible. The cavernous sinuses have also decompressed. And look how the carotid arteries that were pushed laterally by the tumor has now come back into a more medial position. So that's an interesting radiographic finding. Here's another example of, this is a patient who had Cushing's disease, and she had Cushing's apoplexy. And you can see we did an aggressive gross total removal. And this is the immediate post-op scan. Look at the restoration of the normal gland here and decompression of the optic chiasm. So it's important to do a proper diagnostic workup when you see a patient with a pituitary tumor in the office. You need to do a high resolution MRI of the pituitary region with and without gadolinium, a full set of pituitary function labs, and neuro-ophthalmological testing with formal visual fields. You want to do a detailed history. If you suspect acromegaly, you want to elicit questions of enlargement of their hands and feet. I usually ask if they've changed their ring size in males or if they've had any increase in shoe size. You want to ask for any changes in facial features over time. Oftentimes I will ask to have them reveal any photographs of themselves dating back as 5 or 10 years ago. If they have any history of diabetes or hypertension, this should point to Cushing's or acromegaly. Ask for any changes of weight gain or loss, visual loss or diplopia. And in females, you should elicit any galactorrhea or amenorrhea in their history, any heat or cold intolerance, fatigue, or signs and symptoms of Cushing syndrome. So these are the hormones that one should order in the workup. And then, of course, visual field testing, looking for bitemporal hemianopsia. So here's an example of a non-functioning cystic adenoma causing visual loss. You can see the gland has been pushed upwards. This tumor is largely filled with cystic fluid, but there can be always tumor in the walls of the cyst that aren't so apparent on the MRI scan. So here we're doing a standard endoscopic transphenodal approach. We'll open the dura widely, and you can see we'll immediately get into the cystic fluid cavity. And so here's the cystic wall that we're entering. You can see that's not CSF, it's actually cystic fluid. And of course, like I mentioned, there's going to be soft tumor that's within the walls of the cyst that you'll see. This is typical soft curettable adenoma. Some of it's adherent to the dural wall. So we'll use two-handed microsurgical dissection technique using scissors. This is the closed blade scissors technique. And then where it's adherent, we'll sharply incise. And then we'll use our standard curetting techniques to get the cellar barrier to descend. So whenever I'm doing pituitary surgery, I want to see descent of the suprasellar barrier. Here you could see in these large tumors with suprasellar extension, the arachnoid barrier tends to fold on itself and it can be stuck and there can be hidden areas of tumor. So you want to inspect thoroughly these little folds to make sure there's no hidden tumor. And you could see over time with CSF pressures and gradual interrogation of the cellular barrier, it now comes down into the field. Here, the cellular barrier is so large, it comes out of the dural defect, and we'll push it back in with a little bit of gel foam. And you could see this is the immediate post-op MRI, not the 3-month MRI. You could see excellent decompression of the optic chiasm. The pituitary stalk is greatly enhancing, and the stalk will always point to where the gland is, right? So if the stalk is veering to the right, the gland is right here. The glandular material has the same enhancement as the pituitary stalk. So a complete removal. Here's the gland, here's the stalk, and here's the optic chiasm decompressed. Here's another patient with progressive visual loss. You could see the gland is this thin rim of enhancement off to the left, and it's also at the top. So here we'll open the dura widely. The tumor is soft and curettable. And so I start off usually with decompressing the inferior component of the tumor with several gentle swipes of the blunt curette. And once you decompress the inferior compartment, I decompress the lateral compartments to visualize the walls of the cavernous sinus on both sides. And here in this case, the pulsations of the CSF just gradually deliver this nice tumor in a pseudocapsular fashion. And once you recognize this, you want to just gently work and tease the tumor out. You see the nice supracellular cap of the pseudocapsule of the tumor. And there's the arachnoid membrane. This is the cellular barrier. There's always a thin rim of gland here on the cellular barrier. And there are some areas where it's really thin, where it's only arachnoid. So we call those the mixed cellular barriers, where you see pure arachnoid versus arachnoid plus gland. And we inspect, and there's no CSF leak. So if there's no CSF leak intra-op, the repair is easy. I put a little gel foam in the dead space. I don't overpack it. And then I put a single layer of alloderm. No lumbar drain is needed. And you can see it's an easy cellular reconstruction. This is the immediate post-op MRI. You can see the gland has been restored, and the chiasm has been nicely decompressed. Again, here's the pituitary stalk, bright enhancement, and the stalk will lead you to the bright enhancement of the gland. And this is her in the recovery room. Already she can see the clock from across the room, immediate recovery of vision in the recovery room. And this is the gratifying thing about pituitary surgery, is that you can really restore vision immediately. Here's some more examples of large macroadenomas. These are non-functioning tumors that I'm showing. Immediate MRI, you can see decompression of the optic chiasm. Again, this is a partially cystic and solid tumor. This is a 3-month MRI, and you could see nice restoration of the gland and the stalk and the decompression of the optic chiasm. This tumor is a little bit more challenging. The reason why this tumor is more challenging is look at the sagittal scan here. When the supracellular component is wider than the diaphragmatic opening, there's a greater chance that this tumor won't deliver and will get stuck at the bottleneck, and you can be left with residual tumor. And it may require a more aggressive dissection, in which case there's a higher risk of intraoperative CSF leak as well. So these tumors are more challenging. Here's the video showing the techniques. Here we're drilling off the cellular floor into an eggshell fashion to resect the cellular wall. You want to do a very wide bony removal, because this will give you the best access to let the tumor fall out. and then we do a wide dural opening. And I do it in a stellate fashion. And so our initial move is to decompress that inferior compartment using suction curettage. Here you can see the tumor is a little bit more fibrous. It's got a more fibrous pseudocapsule. The inside is softer, but not entirely soft. So there are portions of it that feel soft, but you can see that the periphery of the tumor has a more fibrous component. So here we're doing extracapsular removal. So what I'm doing is I'm putting a little gentle traction on the tumor pseudocapsule and then using the suction to dissect away the cellular barrier. You can see there's a little bit of seepage of CSF, but not terrible. I'm still relying on the pulsations of the CSF to push the tumor out, but I'm going to use a little gentle traction. And then with the suction, we'll use suction dissection to sweep the cellular barrier away from the pseudocapsule. So you can see I'm looking for that interface right there. And you do it in a very incremental fashion. Be very patient. Don't try to pull too early, but here's the cellular barrier. Here, the cellular barrier looks largely purely arachnoid membrane, but you can see how I'm using a suction swiping technique and then just coming around the periphery. You want to make sure your suction is on very gentle power and then just gently sweep that barrier, that interface. And you can see now I've delivered that posterior component of the tumor. You can see the periphery here is very fibrous. And then we can remove that last component. And there's the cellular barrier. It's come down. And so we can inspect. Here's the normal gland. Look at the normal gland. It's right here on the right side. That's the normal gland. And this is the cellular barrier, which is here. It's a purely arachnoid cellular barrier. I'm going to try to reduce the arachnoid with a cottonoid back into its place and then look for any residual tumor. And here you could see the arachnoid barrier has decompressed itself through some seepage of CSF. And you can see here's the normal gland. And there's no further residual tumor that's seen. And we'll pack off the dead space with a little bit of gel foam, a little bit of Surgicel, and I'm going to put an Alloderm inlay here. And we'll use an Alloderm overlay here in this case. Since there was no further seepage of CSF, we used an Alloderm double layer technique. And then we'll pack off with Surgicel, some gel foam, and a Miracell pack here. So here is the 3-month post-op MRI. You can see excellent decompression of the optic chiasm. The gland, remember in the video, the gland was off to the right. And lo and behold, the pituitary stalk points to the right side, which is where the gland was. And this patient had normal pituitary function post-op. So you can still preserve the pituitary gland function if you use this gentle handling of the pituitary gland. I always look for the gland at every step of the way doing these surgeries. And our pituitary gland function preservation rate is 97%. In our series, only 3% require additional new pituitary hormone replacement. So we track every one of these patients and we monitor them post-op. So that brings me to the question, is tumor size a limit for the endoscopic and nasal approach? And for huge giant tumors such as this? And my question is no, there is no limit if the tumor is purely midline. You can see this is a extended transplanum approach. We've decompressed the optic chiasm. We could see the ventricle, third ventricle with the dilated foramen Monroe. And because of our repair technique, using a vascularized nasoseptal flap, we can prevent postoperative CSF leakage. This patient had residual tumor in the cavernous sinus. I treated with IMRT radiotherapy, and this is the 6-year post-op scan. So you could see excellent decompression and tumor control. He's now approaching close to 15 years post-op now. This is a patient who had this large tumor. You could see it go straight through the diaphragmatic opening, and then a huge suprasellar extension going laterally, but also anteriorly along the planum. And this was done through an extended transplanum approach. And this patient had normal pituitary function post-op, no hormonal replacement therapy, no CSF leak due to a good nasoseptal flap repair. But you can see here's the pituitary stalk. It was on the back side of this tumor, and we were able to preserve the normal gland function and decompress the optic chiasm here. Here's another patient. These tumors are very challenging. This goes behind the stalk. The stalk is in the front, and it went backwards here into the third ventricle. And then this was a near total to gross total removal. So it's important to understand the pathway of hyperprolactinemia. Remember that there's a basal level of secretion of prolactin, and that the dopamine or any drugs that mimic dopamine can inhibit the natural negative feedback of prolactin. So if you have a large non-functioning tumor that compresses the pituitary stalk, you will have mild elevation of prolactin, roughly elevated to anywhere between 40 to about 90, sometimes rarely just slightly above 100, but usually they're less than about 100. And this mild elevation of prolactin, it's important to recognize that it's the stalk effect or the stalk compression effect. And it's not a true prolactinoma, because true prolactin secreting tumors tend to have much higher elevations of prolactin, and they tend to correlate with the size of the tumor. So that if you have a small microprolactinoma, this elevation of prolactin can be as high as 150 to about 250 or 300. And as the tumor gets larger in macroadenomas, those elevations of prolactin can be up to 400 or 500, and sometimes even greater than 1,000 if there's cavernous sinus invasion. And in cavernous sinus invasion, they can be as high as over 10,000. So it's important to know these elevations of prolactin. We frequently see non-functioning tumors such as this be misdiagnosed as a prolactin. And we see this in the community where a primary care physician or an OBGYN physician will see a female patient for galactorrhea or amenorrhea, and the initial diagnostic prolactin is 65 or roughly around this area. And so this patient was presumed to have a prolactinoma or a secreting prolactin tumor, and was treated on bromocriptine and cabergoline for many, many years. And meanwhile, the tumor is not shrinking. The tumor continues to grow, and the tumor is now compressing the optic chiasm, causing visual loss. And so this patient saw me as an opinion. And the most important question when you see a patient like this, the most important question is, what was your prolactin level at the initial time of the diagnosis? And that is very important, because if this prolactin level was, say, 400, I would then say, then yes, you probably did have a true prolactinoma. But she was able to give me this information, and her prolactin level was 65. And immediately I said, you do not have a prolactinoma. You have a non-functioning adenoma, and you've been misdiagnosed, and you need surgery. And thankfully she trusted me, and We took out the tumor. The pathology was a non-functioning adenoma. We cured her visual loss, and her amenorrhea, she was able to immediately have normal menses. She wanted to have children, and now she was able to have children, and she now has a 6-year-old son, and has been forever grateful for this intervention. So very important. Recognize misdiagnosed prolactinomas. This is a recent patient I did a few weeks ago. Again, same story. She lived many, many years with terrible visual loss. She was going blind because she was misdiagnosed with a prolactinoma. Her initial prolactin level was roughly around 65, just like the last patient. This is the immediate post-op MRI we did. You can see decompression. Look at the optic chiasm. Look how thin it is. She had very profound bitemporal hemianopsia. The stalk has been restored. She had normal pituitary function post-op, no need for hormonal replacement therapy because we preserved the cellular barrier that had glandular function, glandular material on the arachnoid barrier. So tumors, pituitary tumors, can also extend laterally into the cavernous sinus. So it's important to know the cavernous sinus anatomy. There's the gland in the middle, and as you go laterally into the cavernous sinus, we're met with important critical structures such as the carotid artery, and of course there's the cranial nerves 3, 4, V1, V2, and cranial nerve 6. So very important. What do you do in these tumors that extend into the cavernous sinus? Well, in most cases, the tumors create the corridor into the cavernous sinus. So this is a tumor that creeps into the cavernous sinus, into the temporal lobe. And if you just follow the tumor, if the tumor is soft and favorable, you can simply use angled endoscopes and angled curetting instruments. You simply just follow the tumor into the cavernous sinus, use curved suctions, and you can remove a large portion of this tumor in the cavernous sinus. And this was a very nice result, decompressing not only the cavernous sinus, but the optic chiasm as well. And this patient had no CSF leak and normal, believe it or not, normal glandular function afterwards. So again, applying the same principles, preserving that cellular barrier, because the cellular barrier has glandular material on it, and being very gentle with the cellular barrier. This is a patient who had progressive cranial nerve palsies on the right side due to this recurrent adenoma that was treated at another institution. This thing was completely encasing the carotid artery. So we remove the central portion first, and then we get into the cellular barrier, the lateral compartment here. And you can see there's a little bit of brisk arterial bleeding. This is not carotid injury. It's important to recognize this is just a little bit of bleeding from the meningohypophyseal trunk from the cavernous sinus. And so it's easily treated with a little gentle packing. And then we use a microdoppler to map out where the carotid is. And then you start with a periosteal dural opening in the lateral compartment. And you want to open in a very small incremental fashion. We palpate with a little blunt hook and then open it gently, little by little. And then luckily here, the tumor is soft. And you could start to see, here's the cavernous carotid artery. You could see it's right there. And then we'll do very incremental, gradual dural opening, working ourselves by removing the tumor lateral to the carotid with the gentle curved suction. Here we see the entire course of the carotid artery. And then after we've decompressed the cavernous sinus, there's no CSF leak. We'll put a little bit of gel foam and an alloderm patch graft to reconstruct the sella. And here's the post-op scan. You could see the This was a near total removal, and the cranial nerve palsies were improved. So I want to change gears a little bit and talk about Cushing's disease. These are ACTH secreting tumors resulting in elevated cortisol. And you can see here, she's got the classic central obesity with purple striae, a buffalo hump. And these, as you know, are the classic symptoms to look for. I won't belabor the point here. You can pause and look at the slide on the playback. And then this is the pathway of physiologic pathway explaining how Cushing's disease happens. It's the elevation of ACTH from the anterior pituitary lobe, or from the tumor, so to speak, which then acts on the adrenal cortex to elevate cortisol. And then cortisol goes on to act on the peripheral body to cause its deleterious effects. So it's important to recognize where the tumor is on the MRI scan. Sometimes it can be very hard to visualize, but it's important to do dynamic coronal imaging. And oftentimes the tumors will look hypo-intense to the gland. So here the gland is more hyper-intense. The tumor here looks darker. So we look for that at surgery. And you can see here's the tumor separating from the gland. And we try to do a pseudocapsular dissection. Here, I decompress the tumor a little bit first on the medial side, and then on the cavernous side, I got a nice pseudocapsular plane using suction dissection technique here, peeling it from the arachnoid membrane. And I tend to have more intraoperative CSF leaks on microadenomas than I do macroadenomas. And that's because microadenomas, you want to be more aggressive because these are functional tumors. And when I'm more aggressive with the arachnoid cellular barrier, I tend to have more intraoperative leaks, but these are easily repaired with a nasoseptal flap. And you don't have postoperative CSF leaks. So that's the important thing, is that when you recognize an intraoperative CSF leak, you repair it so you don't get a postoperative CSF leak. And so what we look for afterwards is the immediate drop of post-op day 1 AM fasting cortisol to less than 2. And if it's less than 2, it's a very good prognostic sign that you're going to have a cure or a biochemical remission. And here you can see this is the post-op cortisol. But the most important thing is when they come back to the office and they have a major physical transformation. And I did not recognize the patient when she came back to post-op follow-up. You can see she's got a very happy demeanor, complete transformation of her Cushing's disease. And this is probably the most grateful part of doing pituitary surgery, is curing Cushing's disease. You could see excellent, amazing transformations pre and post-op. And this is another example of an amazing transformation pre and post-op. So you could cure their medical ailments, but also transform their physical appearance. This is a 17-year-old with Cushing's disease with this larger tumor. This is a macroadenoma. You can still cure Cushing's in some select cases of macroadenoma. I want to show you a technique where we're trying to do the pseudocapsular dissection, opening the cellodural widely. And you can see the tumor is very soft here. And so, we've already opened the dura and the tumor is already spilling out, much like you see in a traditional non-functioning adenoma. We'll go ahead and open the dura widely. And you can see already the soft tumor coming out. So we can't do a pseudocapsular dissection. Obviously, the tumor's pseudocapsule has already been entered. And so we'll just commit to aggressive curettage of the tumor in the standard fashion. This is just some venous bleeding from the cavernous sinus. and the circular sinus. So I generally just work through it, work efficiently through it. It's only venous bleeding, so it's easily controlled with gentle packing. So I just work through it because I don't want to obscure my visualization. And then we're continuing to curette out the tumor. And then as we get to the periphery of the tumor, you can see this looks like the normal gland. This is the sellar barrier and the medial wall of the cavernous sinus on the left. And because this is Cushing's, I'm going to incise a layer of the boundaries. And I think this is an important technique because this is going to give you a higher chance of getting a cure. So I'm going to take an arachnoid knife here and then just make a small incision in the gland in the periphery. And then I'm going to take this sharp dissector and I'm going to create a plane here. You could see there's a hint of a pseudocapsule layer on the periphery of this gland. And it's okay to cut into the glandular material. I mean, as long as you preserve, good volume of the rest of the gland, you'll still preserve pituitary function. And so here, we found the pseudocapsule. We've picked up a micro layer of the pseudocapsule that you probably could not visually see. But there is a pseudocapsule there. I had a suspicion there was one. And even if there was one, I was going to resect the rim of the gland anyhow to get a higher chance of biochemical cure. And so there is the pseudocapsule. And then again, using the suction, dissection, sweeping technique, put a little gentle traction on the tumor. And with the suction, gently dissect and swipe right at the interface to gently tease it off. So we're using that gentle suction dissection technique. And then we eventually remove that last portion of the pseudocapsule. And then I use these very micro alligator forceps to remove the last component of this. Being very meticulous, being very aggressive here, because this is Cushing's disease. You want to get a cure. And then I'm just going to inspect every last bit here. And then this is the final view you could see. And her post-op cortisol was less than 1.0, almost undetectable. A biochemical cure. She had, again, physical transformation and an excellent result. So it's important to recognize that Cushing's disease is not in females, but males can get it too. It may not be as, it may be more subtle, the findings, but this patient had weight gain over a course of a number of years, and he was feeling very fatigued, not feeling well at all. Luckily, his endocrinologist diagnosed Cushing's disease. You could see he's really not doing well physically, and he has a tumor here, a microadenoma. And so here's the tumor. You could see the MRI saying the tumor is on the left, and you want to look for these findings. Look at the tumor. Even through the dura, you can see there's a hint or a clue that the tumor is on the left. And then when we open the dura, the tumor is indeed on the left. And we do a selective microadenomectomy. You can see this is the resection cavity, the sellar barrier, the arachnoid. The normal gland is preserved here on the right. We preserve his normal gland function. and his post-op day 1 fasting cortisol was 2.3, not quite less than 2, but very close. But I repeat it on the second day, and it's 1.0, and he undergoes remission. You can see he was not lacking any. He was lacking hair on his shin pre-op, and then once he was cured, he started to grow hair back, and you could see the color of his skin is better. The plethora that you get in the classic Cushing's disease has dramatically improved. And you could see he looks much healthier now. He looks younger, healthier. He looks back to when he was in his healthy state. So an excellent result. Changing gears, acromegaly, growth hormone secreting tumors. These are classic for elevations of growth hormone to IGF-1 to get enlarged hands and feet. You can see this is a patient who has acromegaly with enlarged hands and feet with diabetes. And in this case, the tumor is small. So even small tumors can cause deleterious effects. This is infracellular below the pituitary gland. And we were able to get a post-op day 1 growth hormone level of 2.4 and 1.3 at 3 months. And you could see the IGF-1 will normalize at 3 months. And so she had a curative removal. This is a macroadenoma. You could see acromegaly patient, post-op day 1 growth hormone of 1.1. This is suggestive of cure. On post-op day 1 growth hormone of less than 2, and you could see excellent decompression. So here's another example. This is a recent case we did. Acromegaly, you could see the gland is on the left, the tumor's on the right, and a complete removal here. So we can potentially get a biochemical cure. But if the IGF-1 levels are persistent, remember there are medical options, somatostatin analogs. You can use growth hormone receptor antagonists. If the tumor is in the cavernous sinus, I think radiosurgery is an excellent option, and we've been able to achieve biochemical remission in residual tumors in the cavernous sinus with CyberKnife or Gamma Knife radiosurgery. What about this giant tumor? This is a giant tumor extending through the petrous apex of the skull base, invading the bone, very invasive with this cobblestoning effects. This is a very challenging tumor. How would one approach this surgically? And I always show the residents this case. What is the best approach for this giant invasive tumor? And 9 times out of 10, people will suggest this approach or that approach surgically. And it's always important to remember to ask the prolactin level. So the prolactin level was normal, or is it normal? It's important to remember the dilution of your prolactin. This is called the hook effect. So if the prolactin level is massively in the tens of thousands, it can alter your serum assay where it saturates the binding sites of the assay. So you get a falsely normal appearing prolactin. Ask the lab to do serial dilutions if they don't normally do it already, and you can see that the corrected level is greater than 35,000. So this is the hook effect. And the treatment here is medical. And the success, you can see the tumor has shrunk to post bromocriptine. So the treatment is medical for prolactinomas, dopamine agonist therapy with bromocriptine or cabergoline. Bromo is cheaper. More GI side effects, and you have to take it daily, sometimes twice daily, whereas cabergoline is more expensive, but is more potent with less side effects, and you take it twice weekly or twice a week. And then we reserve surgery if it's medically refractory to medical therapy, and sometimes you could do radiation. In some cases, we will do surgery as a curative option, the way we think about Cushing's disease. So this is a 22-year-old female who had galactorrhea amenorrhea, and the prolactin level is 178. She was non-compliant to medical therapy. She actually refused medical therapy. And you can see with a tumor like this, it's curable. It's not a huge tumor. It's not invading the cavernous sinus. And if the prolactin level is less than 300 or 350, I will offer them curative surgery. And our curative cure rate for microprolactinomas is on the order of 95%. So I think if your complication rate is low and they're curable tumors and they've either failed medical therapy or they're not amenable to medical therapy or refusing, you can potentially get a cure in these types of cases. And this is the post-op resection. You can see post-op prolactin level less than 10 is often indicative of possible cure. This is another case of a 15-year-old, prolactin level of 196. She actually failed medical therapy, and we got her prolactin level down to less than 10 on post-op day 1, curative resection. I just want to lastly briefly talk about craniopharyngiomas. These have the extended approach has largely changed the way we've done craniopharyngiomas. They've largely been done through craniotomy, and the ability to do endoscopic surgery on these have been a game changer, and largely because we can visualize the undersurface of the optic chiasm and the hypothalamus. So we do need to remember to individualize and take a personalized approach to craniopharyngiomas. This is a child, a 12-year-old boy I treated with this huge mixed solid and cystic craniopharyngioma. This is the endoscopic transplanum transtubercular approach. Notice the working corridors all underneath the chiasm. And once we deliver the tumor, we have a beautiful view of the hypothalamus. We have a beautiful view of the optic chiasm. Here's the pulsations of the membrane umbilical and the basilar artery. And of course, CSF leak repair to prevent post-op CSF leak has largely been successful with the nasoseptal flap. And this is the post-op scan. You can see complete restoration of vision. He had hypopituitarism, which was placed on hormone replacement therapy. And he's been recurrence-free now for over a decade. He's now an adult, and he's done quite well. So some tumors may not be amenable to endoscopic approach. This is one where I felt this was better through a translamina terminalis approach. And coming in transbasal, I think, as opposed to a terional, gives you a better view of the lamina terminalis because you have a direct midline view as opposed to an oblique view, which is the other alternative. Here's a video demonstrating that approach through a transbasal translamina terminalis approach. You have a beautiful view of both sides of the both sides of the walls of the third ventricle, and you can bring the tumor down into the field. Here's the walls of the ependymma. There's the basilar artery, and you could see a wide opening. However, there's still a limitation. This is the blind spot. When you come from the approach from above, it's hard to see the undersurface of this area, and this is an area where you can get residual tumor. So this is I think a very satisfactory resection. You can see there's a little enhancement here underneath the chiasm. These are the hidden blind spots. And if you follow the patients long enough, you'll see some early recurrence. And we treated this recurrence with radiotherapy, and he's been stable for the last 10 years. So I think this is where again, the endoscopic approach has some advantage, which is this ability to look at the undersurface of the optic nerves and the chiasm and perforators. So here's an example. This is a large cystic and solid tumor. I treated this initially endoscopically for the goals of decompressing the optic chiasm. I felt that we could decompress the optic chiasm more effectively. So here we're demonstrating a transplanum, transtubercular approach. And then we get into the tumor initially by opening the dura. You can see the cystic fluid has extruded. It's got the classic greenish appearance of the fluid that you see in craniopharyngioma. And then we dissect in the subarachnoid space. Now be very careful of these small perforators. These are not tumor feeders. These are perforators from the medial carotid, which are the superior hypophyseal perforators that will give blood supply to the optic chiasm. And if you're not careful and you injure these, you can get postoperative blindness or visual loss. And so here you could see this is a very invasive tumor. Here's that perforator I mentioned. Don't coagulate this, but dissect it out. And if you follow this perforator, it's going to go back to the chiasm. So we're using sharp dissection, incising and dissecting that perforator away from the tumor. And then here's the PCOM going back. And we can find the pituitary stalk here by elevating the tumor, look for the gland, and look for the portal striations of the stalk. And here you can see as I'm dissecting the tumor away, I can follow the stalk. And in this case, I'm going to preserve the stalk here because we can preserve it. And there's no need to sacrifice the stalk here because the tumor is not invading the stalk. And so we'll go ahead and dissect the rest of this tumor cyst out. And you can see the tumor here is wrapping around the right optic nerve here. You can see the right optic nerve is encased by the tumor. It's going to be very difficult to cure this because look at the ACOM. This is the ACOM. This is the Hubner A1. Hubner and A1. Look how it's encased by the tumor. It's going to be very dangerous to try to aggressively remove this. So what I'm going to do here is I change my goals. I'm going to go for the most maximal safe radical resection. I was able to incise the tumor and free it so I can remove the retrochiasmatic portion. Here's the tumor being dissected from the membrane of Lilliquist. There's the basilar artery coming into view. And then I'm going to dissect the tumor from the undersurface of the chiasm. Remember, this is the major advantage of the endoscopic approach. I'm going to sharply dissect the tumor from the hypothalamus. And then here's the basilar artery. And we'll go ahead and remove this portion of the tumor. There's the basilar artery again. And once we've freed up this portion of the tumor, we can remove this component. And then this is the final view. This is the cystic portion here in the frontal lobe. I cannot reach all the way here endoscopically with my tools, but I've achieved my goal of maximal safe decompression of the solid component. The visual apparatus is decompressed. We reconstruct with fascia lata and then a nasal septal flap that you see here. And so this patient had normal pituitary function post-op, some transient DI, and the vision restored. You can see this is the cystic component that has been decompressed. And at 3 months post-op, you can see the cyst has further regressed. And at this juncture, I have the option of doing a second surgery to try to resect the cyst. But I know that at the first surgery, it was encasing the ACOM, so I knew I wasn't able to get a theoretical complete removal. So I treated with IMRT radiotherapy, and you could see at 16 months after radiotherapy, the cyst has regressed, and patient did very well. And we published that video in Neurosurgical Focus you can find online. So when is the open approach necessary for craniopharyngioma? Look at this laterally appearing cyst. Better done through a orbitozygomatic transsylvian approach. You can see the tumors largely removed through the carotid oculomotor trigone. And we got a radical near total removal. You can see the basilar artery in the carotid oculomotor triangle. And we got a near total removal. We treated the residual with IMRT. And then here's an 80-year-old who had previous surgery on the left side at another hospital. She was blind in the left eye from that surgery. And now she has a recurrence that someone else did an Ommaya catheter that failed miserably. Which doesn't work. Ommaya catheters don't work for craniopharyngioma in my experience. So it's continued to grow. So we did an eyebrow approach here. This is a transciliary supraorbital approach. We come in transcortically initially to control the cyst. That's going to be hard to see in the subarachnoid space. So we come at it right through the transcortical approach. And we dissect the cyst from the parenchyma of the frontal lobe. And then we come in through the subfrontal subarachnoid space. You can see there's a lot of scar tissue here from previous surgery. These redo surgeries can be quite challenging, but you need to do sharp dissection when you're doing scar tissue. Blunt dissection will result in complications of avulsing neurovascular structure. So we piecemeal dissect in a sharp dissection fashion. And sorry. And with piecemeal removal, we can dissect away this tumor. And then here we're going to use an arachnoid knife. This tumor was really adherent to the optic nerve. But one trick that I use is I use an arachnoid knife and I cut right on the tumor capsule. And if you sharply cut on the tumor capsule and you find the smooth plane of the true tumor capsule, the fibrous adhesions of the scar tissue will be released from the tumor capsule and it will fall away towards the side of the optic nerve and the vascular structures. So we're cutting right on the scar, and the scar will mobilize and go to the side of the neurovascular structure. So this is a nice technique to do when dealing with scar tissue. So here's the final view, and the patient left in post-op day 2 with a near total resection. So another option to consider. And then lastly, you could see this giant multicystic tumor encasing the A3s, A2s. And you can see we did this through an interhemispheric transbasal approach through the lamina terminalis as well. And we got a near total removal. And I'll conclude there with this talk with craniopharyngiomas. And I'll be happy to take any questions.
Thank you very much, Dr. Liu, for that amazing lecture. If anyone has a question for Dr. Liu about this topic.
Hey, Harshad, welcome.
Hi, James.
Welcome.
Hi,
morning.
James. Good morning, Dr. Harshad Parekh from Mumbai. How are you?
Hi, good. How are you? Good to see you again.
Yeah. Excellent. Wonderful presentation and wide variety of cases you have shown and midline approaches and lateral approach, laterally going tumors and going. It's wonderfully done. And as you are always a master technician, I have seen you many times in your webinars. The few things which came to my mind when you were doing, we do the same way, in the same way like pituitary, if it is a straightforward supracellular also, we do transsphenoidal and not thinking of any other approach. Many times extending to the cavernous sinus, I try to also go through that. Now, I agree with you. One thing is if there is an hourglass defect, means the tumor is entangled at the diaphragm. It is difficult to remove. In these cases, we have enlarged the diaphragm and removed the tumor. Of course, there can be a possibility of the CSF leak. One more thing I was thinking, your opening of a dura, which is more to the 12 o'clock or 1 o'clock I've seen. We prefer to do at 6 o'clock opening and open the dura and lift it like a flap and try to dissect the tumor first from the inferior portion, then lateral, and then go to superior so that chances of getting leak is less. What is your experience in this?
Yeah, thank you for those excellent comments. I agree with you in terms of my thought process and stepwise removal. I start the tumor removal like at 6 o'clock, as you mentioned. And then after removing the 6 o'clock component, we then remove and go lateral and define the medial walls of the cavernous sinus. And as you gradually remove the inferior component, the top portion will slowly drop down due to pulsations of the CSF. And there's many tricks that you can do to get the top portion to come down. We want to keep the stellar barrier intact and the CSF the CSF inside and rely on the pulsations of the CSF. We start with a Valsalva maneuver that can push the tumor down. And as you Valsalva, you take your curette and sort of gently encourage the tumor to come down. If that doesn't work, you can use bilateral jugular venous compression, and that's also worked very effectively. And then we use a 30-degree angled endoscope looking upwards. And as you look upwards, you can visualize that barrier. And sometimes you can just, if they're very soft tumors, you can just use your suction and then gently suction the tumor till you recognize the interface of the cellular barrier. But if it has a firm pseudocapsule, then I use the technique which I showed you, where I grab the pseudocapsule with a forceps, and then with the suction to gently dissect the arachnoid away from the pseudocapsule. So those are different variations that you can see.
Yeah, we call it extracapsular, subcapsular. Always we try to dissect it out and with the suction or with the curette and remove it. One more thing, I totally agree with you. Many times we feel that this tumor may be extending laterally or supracellular, and you may not be able to remove from transsphenoidal. And we are able to remove it in majority of cases. What has been described by my good friend Atul Goel, he says this is within the confines of dura. The tumor rarely transgresses the dura, and it elevates the dura. So you are able to remove the tumor significantly through the same opening rather than going through another approach. The problem which we face is if the tumor is going retrocellular, behind the cella, then there is a problem that how do you go there? Even the 30-degree endoscope many times may not be able to see it. Or if it is going subfrontally, in that case, we may have to drill the further like tuberculum celli to get into that subfrontal approach, or maybe retrocellular, you have to go further down, maybe towards the clivus area. What is your experience?
Yeah, great questions. I think if the tumor is extending more anterior above the planum, then you have to do a transplanum approach and drill off the planum, open the dura, and follow the tumor in the subarachnoid space. And then for retrocellar, you have to make an opening in the dorsum cellae, so you can remove the dorsum cellae and posterior clinoids, and sometimes drill the back of the clivus to get more exposure. So doing the extended approach is one thing, and then reconstruction is another challenge afterwards, because now you've changed your extra arachnoid surgery into a subarachnoid surgery. And so you need to be able to successfully repair the defect and prevent a post-op CSF leak. So that can be challenging as well. And so I think it's important when you do that to use a multi-layered repair using, I like to use autologous fascia lata as the initial layer. And then we used taco seal, which is a fibrin sealant, and I use it as a second layer, as more like a Scotch tape to seal down the fascia lata, and then use the nasoseptal flap, as our final barrier with postoperative lumbar drainage.
Right. Very nice. And the issue is, many a times packing of the sella. In my experience, I have found in one patient was little more packed, and patient had deteriorated in the vision. And despite of removal of a pack immediately, still I find vision was not improving. And I couldn't find any other reason. There was no infarct. The chiasma looked okay. But in the first post-op scan, I found that vision has deteriorated because the chiasma was lifted up, although the tumor is removed. So it means there was overpacking. And we believe also to don't overpack the sella with the fat or even with any other material. So do an optimal, otherwise it will lift the sella again, because you are putting, in spite of the tumor removal, you're packing it with more material. So it may compress it. And apart from compression, the vascular injury, especially in older age, is very, very common to be seen in this kind of cases. This was my experience in this kind of cases. About the prolectinomas, we have started doing this serial dilution. And many a times we have found double dilution, serial diluters, with what we say, it is less than 100, and then found a lot, it goes into 500, 600, and 2000. I personally observe these cases if it is elevated prolactin level, and if there is no vision involvement, then I observe every 6 months we do a scan, and then if there is any involvement, then we think of doing these patients. Despite of what you said, I agree, it is a compression of the pathway which give rise to the rise of the prolactin levels. We give cabergoline and keep the prolactin levels under control and wait for that. If only cases where prolactinomas we operate if there is a vision threat or patient is losing the vision. This is what my experience is about prolactinomas, and we have seen this happening and able to control. There was one lecture I heard in Japanese series. They operate all prolactinomas, all prolactinomas, irrespective, no medical line of. They said no, you should remove it. And the people have different approaches and different ways of tackling it. This was my personal feeling about the prolactin levels, and quite a few patients are still under observation. Only patient has a threatening vision or wants to conceive, then yes, one should go for a surgical aspect. This is what I feel. About the craniopharyngiomas, yes, which are restricted within the cell and going little bit anterior to the cell, one should try to remove it rather than going for a multiloculated and large tumors. Wonderful job, James. Wonderful. Very impressed.
Thank you.
Thank you for that comment. I see Sahid Taha has a question for Dr. Lu. Said, go ahead.
Yes, thank you very much. I'm Saita from Rainon Island, Thank you very much, Professor Liu, for this wonderful presentation as usual. I have some question. I want to understand. I will know if you use petrosinus catheterization in cases of difficult diagnostic between peripheric and true ACTH adenoma.
Yes, great question. Yeah, we do use inferior petrosal sinus sampling in our workup for Cushing's disease. I think if the diagnosis is obvious, the standard workup of 24-hour urinary-free cortisol, dexamethasone suppression testing, and also midnight salivary cortisol, if all of those are positive and there's a clear, visually apparent adenoma, we generally don't do IPSS, but I think if the radiographic MRI is difficult to see obvious adenoma, or if there's a diagnostic dilemma, I think IPSS can help you to some degree. It has been said that the IPSS is more effective in differentiating central versus peripheral, and not so much as to localization. The localizing of left versus right tends to be not as accurate, but nevertheless, we do use that data to see if it can help guide us. But nevertheless, at surgery, we do a very thorough exploration of the gland, regardless of any lateralization. I think it's important to be very aggressive because in some cases you may have more than one adenoma within the gland. And, those cases tend to be the most challenging when there's no clear-cut adenoma radiographically or intraoperatively, and you have to make decisions as to how you manage that. I think one technique that has been described in the literature, which we often will do on those difficult cases, is doing an aggressive hypophysectomy where you preserve the top layer of the gland that's adherent to the stalk and sort of do a majority 2/3 resection. That was described and published by Dr. Lillehei, and we generally do that, which has been effective in some cases.
Thank you. I have another question. In case of Hutch adenoma with non-secreting adenoma with the perforators arteries from communicating artery are in the tumor, do you go for surgery?
You're saying if there's a tumor that's encasing vascular perforation?
Yes, encasing the posterior communicating artery with the perforators.
Yeah.
Perforating arteries, yes.
Yeah, I mean, those adenomas that you are describing are the more invasive type of adenomas.
Yes.
And those are the ones that are not confined to the arachnoid, but have invaded the arachnoid into the subarachnoid space. And those tumors are extremely challenging, and they're often met with a much higher risk of complication, especially complications of vascular injury, postoperative vasospasm, and stroke. And I've encountered those in my own experience. And so you have to be very careful and conservative. Those tumors we will generally operate on, of course, if there's visual compression, and the goal here would be for optic nerve decompression. And any tumor that's adherent to vascular perforators, you have to be careful not to injure the perforators. It would be difficult to get a clean dissection around these arteries, and so better to be a little bit more conservative here and leave small residual tumor that you can treat with radiosurgery.
Yeah, I put this question because I did decompression of huge adenoma encasing the posterior communicating artery. Unfortunately, I had a problem with the one perforating, and the patient had peduncular ischemia with the thalamic ischemia. So it's very dangerous.
Agreed.
Thanks, Saeed.
Thank you very much.
Thank you for your question. Trong, do you have any comments or questions?
You're muted.
Hi, yeah, so I have a question from the audience in Vietnam from Dr. Huan. If there's a tumor that you see the tumor that large and with a scar tissue and expanded into like supracellular area and also laterally, and you cannot get in from the you know, the endonasal approach. So what is your thought at that time? Should you stop the surgery and try to plan for a second stage surgery to remove the tumor, or you should do in the same stage approach from above?
That's a great question. By the way, I just want to introduce the audience to Dr. Trong Hyun. He's one of our stellar residents in our residency program at Rutgers, and he's representing our Vietnam audience and translating for helping translating. So the question that you're asking is about giant pituitary adenomas, and it's important to recognize that in giant adenomas, which we define as greater than 4 centimeters, you have to be prepared and plan ahead in terms of the surgical approach, whether you come from above with a craniotomy first, or endonasal first, or a simultaneously combined. And the issue here is, understand that in giant adenomas, if you get an incomplete removal, you have a very high risk of a phenomenon called postoperative apoplexy, where a partial removal results in necrosis or hemorrhage into the remaining residual tumor, because what you've done is you've woken up a sleeping giant. And there's been numerous anecdotal and published reports of patients who will, you know, have herniation overnight and result in mortality. And that's been well documented. And so you have to be prepared to remove the residual tumor up front. So I prefer to do a combined approach in a single stage. And whether you do that from below first or craniotomy from above is variable. It really depends on the tumor appearance and location. So if the cella is nicely expanded and you know, it looks like you can do a large portion of it endonasally, I will sometimes do endonasal first and then be prepared to do a craniotomy second. There are some cases where I've done, you know, vice versa, the other way around. But the important thing is to remember that if you don't get it all, you could risk having post-op apoplexy. So I think I would prefer to do it at the same stage. You're muted, Trong.
I think he's translating the answer. Yes.
Oh.
So we also have a question from Nicole Fuentes. I think you're already like starting given the response to that, but she's asking how you can select the approach endoscopic versus endonasal. Endonasal versus the renal approach.
Yeah, good question. I think it depends on the symptoms the patient is having. So if the symptoms are visual loss and a midline endonasal approach would give you the best optic decompression, I would do that first and then do a lateral approach. Usually a terional is adequate, sometimes an orbitoterional to get the remainder for if the tumor goes lateral. In the instance where I would do a craniotomy first is if there's a lot of mass effect on the temporal lobe or brain from a laterally component tumor that you need to make sure you decompress so you don't have shift. I would do a craniotomy first.
Okay. Does anyone has a comment or more questions?
Okay, I'd like to thank you, James. And we didn't see it, but the Trong says that there are 24 Vietnamese neurosurgeons watching. So that's your time is being well spent in education, and I'm sure they appreciate it. And it looks like his screen is frozen. But anyways, James, okay, we'll wrap this up, and thanks, Andrea, and thanks everyone else for participating, and we'll see you next week.
Thank you very much.
Thank you.
Okay, thank you.
Thank you, Jim. Thank you. Thank you.
Thank you,
Thank you.
Professor. Goodbye.